Hey folks, welcome back to Ground Game. I'm Sam Chapman. Today's conversation is with Dr. Matthew Hicks. Matt is a naturopathic doctor, an Oregon licensed psilocybin facilitator, a member and actually chair of the Oregon Psilocybin Advisory Board, and he's the founder of the Synaptic Institute, which runs one of Oregon's leading facilitator training programs. He's also the lead investigator on what I think is one of the most important pieces of research to come out of Oregon's psilocybin program so far. It's the first clinical trial ever conducted inside a state-regulated psychedelic program, and it's the first psilocybin study specifically focused on a low-income population, the people who clinical trials have systematically failed to reach and that public payers have systematically failed to serve. The findings are incredible. A group format that cut the cost of treatment by more than half, meaningful drops in severe depression scores, and one of the strongest measured outcomes was something that I didn't really expect to see: participants' ability to function socially. We get into all of it in this episode: the design choices, what worked, what surprised Matt, and what he would do next with another tranche of funding, and why the study is exactly the kind of evidence that could move the needle on states investing in psilocybin therapy. But before we get into all of that, I want to give a quick word from one of our partners on the show. If you're listening to this, you're already paying attention to the psychedelic space, which also means that you might be a little tired of drinking from what is the fire hose of psychedelic momentum today. There's a lot happening in this space across science, policy, regulation, culture, and it is genuinely hard to keep up with. The thing that I subscribe to that actually helps me keep up with all of that is Tricycle Day. It's a thrice weekly newsletter that covers the psychedelic movement, from clinical breakthroughs to shifting regulations at the state level to guidance on responsible use. It's written for smart non-experts, which I think is the right type of folks for this audience. And I actually think it's fun to read. Most of these things aren't that fun to read, which matters more than people give it credit for. If you've got a friend that keeps asking you questions about psychedelics, I know that I certainly do, send them Tricycle Day. If you want a smart, accessible feed of what's happening across this space, subscribe yourself. Over 90,000 people have already subscribed. It's free, and the link is in the show notes. Now, to the conversation with Matt. Matthew Hicks, thanks so much for coming on Ground Game. Really excited for this conversation today.
Yeah, thanks for having me.
Yeah, so let's just dive right in. Most of the psychedelic research has been happening at the clinical level, Johns Hopkins, NYU, with super carefully selected participants. You have recently done something different. You created a study within the Oregon program, and you recruited people that the program and arguably clinical trials have failed to reach in a lot of different ways. Tell us about the study and what made you decide that this was a study that you wanted to do specifically with low-income populations.
Yeah, thanks, Sam. So there's a couple ways in which my study was unique. You know, it was the first to be done as a clinical trial within a state-regulated program. And it was also the first to focus on a low-income population. And it was also among the first few. There's been a few studies that have used a group format, and there's been a few that have used actual psilocybin mushrooms rather than a synthetic, but not a lot. So it's still kind of early stage in those categories as well. But I felt like, I just happened to live in Portland, Oregon, and have been around for a long time. I was involved in the campaign, as you, of course, remember.
Yes.
And it just seems like it makes sense that we should be doing research in this program, in this format. And it's different than what most researchers are used to. Usually you get FDA permission, and you follow these sort of strict protocols that are just par for the course. And working within the state model is very different. It's very complicated. State rules and laws do not always interact or overlap perfectly with federal rules. So there were a lot of things to figure out in this process. As soon as I'd figure one thing out, the IRB would come and say, well, you need to do this and that and the other thing, because that's the model they knew. Right. And so there was a lot of negotiating and explaining to get approval to do this study, but we got it done. And part of what I wanted to accomplish with it was to demonstrate that low-income population can benefit, that we can do these sort of clinical trials in a state program in a real-world way, right? So a lot of psychedelic studies up to this point have been very much efficacy focused, which is more of a kind of a scientific proof of concept. Does this do better than a control group? And is it going to perform well in that way? But in the real world, you don't have carefully selected groups. You have people with multiple diagnoses. You have a lot of more hurdles to overcome. Often you don't have participants getting paid. They're paying to participate, right? And so those sort of dynamics just tend to be a little bit different. And so in the end, it's more useful from a lot of perspectives. Not everyone's perspective. Of course, the FDA is primarily concerned with safety. If they approve something, they want to know that it's safe, and that's their primary criteria. But they're also looking at scientific validity for it versus a real world perspective. You might be more interested in like the economic impact of these. Is it cost effective?
Yes.
Right? These are very different questions with sort of different research designs needed to answer them. And so those were some of the things that I was thinking about. And being in Oregon, kind of a unique perspective that I've had is watching the conversation shift from legal access, like we got to create legal access, and then we did it. And then it's like, well, now it's too expensive and no one can afford it. Not no one, but not everyone. Right?
A lot more people could if we could address it, right?
Yeah. Right. And so how do we start, answering that or addressing that problem of economic affordability? And one of the ways you do that, obviously, is through insurance coverage. And the way you get to insurance coverage is you usually start with Medicaid and Medicare. Right. Because that's the biggest system in the U.S. And if you get them to approve something, usually private payers will follow suit. So it was sort of this two-edged sword of like there had been no study on a low-income population, no psychedelic study ever done. So it's
wild,
unique in that way, but it's also strategic to kind of look at the biggest healthcare payer, like a Medicaid population, and say, hey, it can work for them too.
Right.
So that was sort of the emphasis of the reason why I wanted to design this study the way.
Yeah. Well, you're using some of my favorite words, which are not everyone's favorite word, but fiscal economic case is something I say a lot these days. So I want to put a pin in that. But real quick, beyond the income criteria, who walked through the door? I mean, what did this cohort actually look like in terms of age, race? What were they dealing with from a behavioral health, a perspective, and where were they coming from at this point in their lives?
Yeah, and this, is also worthy of mentioning some of the limitations of this study too.
Yes.
This is just a feasibility study, so it's very small. There was no control group.
Yep.
And as a result of that, we just didn't have a lot of funding to do a bigger study. So this is sort of like an early phase, and hopefully the results we got will encourage others to fund a larger version of this study that can really demonstrate potential benefits in a more substantial way. Right. But we focused on depression in Medicaid eligible folks. So Medicaid wasn't involved in any way, but we just looked at their income criteria and said, okay, that's who we want to focus on, and depression. But we didn't exclude people who had other conditions. So we had several people who also had anxiety, a few people with maybe some, I'll say, light trauma. We actually turned away some people whose primary diagnosis I felt was like significant PTSD, and that didn't feel like a good fit.
Sure.
But people with, chronic pain and other conditions that in a typical sort of FDA route study probably would have been excluded.
Sure.
Because, you want to ask the more rigorous scientific question, does this work for depression and depression only? But that's not the real world. Most people have a mixture of these things, and life is complicated, right? So,
Right.
so that was the population. We also wanted to be mindful of sort of the disruptive nature of psychedelics too. And so that also means, especially in working with a low-income population, we don't want to bring in someone who's actively experiencing domestic violence or is struggling with homelessness or some of these other issues. And we also had limitations of what we could offer in terms of follow-up care and psychotherapy. So we required people to have established relationship with a psychotherapist that they could go to for additional support. So we had these additional screening criteria. So it wasn't just anybody who's depressed on low income, because we felt it would be irresponsible to take someone and sort of shake them loose further when their life is already a little bit stressful, in that way. So we want to help the people we can help. That was the goal there. But we also, didn't cast a super wide net. We sort of marketed the study within our existing community. So one of the outcomes we looked at was we did an expectancy questionnaire, which doesn't replace a placebo, but in a normal and sufficiently distributed population, you can look at expectancy effects and see basically did the optimists do as well as the pessimists, right? But you need a distribution of optimists and pessimists in a group in order to see if there's a correlation with the outcomes. And what we found was that this expectancy questionnaire, which is about 6 questions, how do you feel about this intervention? Do you think it's going to help you? That sort of thing, asked before they go through it. What we found was this group was incredibly optimistic. And this is probably a challenge for a lot of psychedelic studies, just because of so much hype and optimism about them. It's hard to find someone who's willing to participate but also skeptical.
Right.
So that might be, doesn't mean we shouldn't ask.
Right.
It's a simple enough questionnaire and it's good data to collect, but it could be hard. So all that to say is we only got optimists, which is part of this challenge also in the unblinding effects, where placebos aren't good controls in psychedelic studies, but the expectancy that it's going to work is the primary thing we're looking at in a placebo. So in other words, if people think it's going to work, they're going to get some benefit just from believing, in it. And so that remains a challenge that I don't have a fix for exactly. But I do have some ideas around, ongoing research that might just be more useful than placebo controls. And I can say more about that.
Well, I'm kind of do you have a hot take that you're willing to share on this? It feels like maybe you do. I don't, and if you don't, that's okay too. But, what I'm hearing from my non-scientific background is, there are the natural controls from, clinical and just general real world research. And this has been a hot topic, especially in terms of some of the FDA conversations, I think around MDMA, right? Like there is big placebo and or blinding issues with that. And that was used to discredit some of that research. Is it a necessary function? If not, what are some of your ideas in terms of what are we actually trying to get at? And what are maybe some of the tools that you would use if you got to kind of write the playbook on how we get to define the parameters of what useful research really looks like?
Right. Well, first of all, I mean, it's fairly obvious, and most even non-scientists know that it's important to control an experiment, right?
Yes.
So you can't just only look for the result that you're hoping for, because you'll probably find it. You have to have something to compare it to that adequately has an inert effect, right? But even outside of psychedelic therapies, we already know that placebos are not totally inert. right? And there are certain conditions that are more prone to placebo effects than others. I mean, they've done studies where they've done sham surgery, where they have literally done knee surgery on people, where they literally cut people's knees open, don't do anything other than just seal it back up. And those people report like effects that are almost as good as actually doing like knee repairs.
Wow.
So so placebos are really powerful. If you believe you're getting a treatment, you in a lot of cases get better from that belief. And so
and we're veering into consciousness outside of science at that point, right? Like, like the belief system. That's a very interesting.
Yeah. And so placebos are not perfect, but they are they're the gold standard, and they have just been the gold standard for so long that so many regulators just see it. This is just what we do because that's the way we've always done it.
Sure.
And I'm not anti-placebo here either. They are very useful and necessary, and sometimes the best we can do in a lot of research designs, but they have these limitations, right? And so then you have an intervention like a psychedelic therapy where the experience is extremely powerful and extremely subjective, and you can't replicate it with a placebo. It's just like you immediately know if you got the placebo or not in most cases. And they've tried it with other stimulants and supplements and other things that have sort of minor effects, but not necessarily psychedelic effects. And they're doing the best they can. But I think what is a better replacement in terms of controls is to just compare outcomes to treatments we already know are relatively effective. Right.
Yes.
So comparing it to, one person gets therapy X and another gets, therapy Y. And we already know a lot about X because we've been doing it, and we kind of have a sort of a expected outcome, a rate of effectiveness from a well-established treatment. And that is what really helps in the end, is what helps payers make a decision. Payers they don't make any decisions based off of placebo controls. They want to know because providers don't prescribe placebos, right? So if a payer, like a health insurance provider, is deciding, do we cover a new treatment? They want to know, is this treatment going to save us money compared to a different treatment that we already cover? Right. And so comparing the standards of care is useful. Waitlist controls are useful. You can't really do a crossover design very easily with psychedelic studies, but you can do what's called a step wedge, where you have basically a waitlist control group where they don't immediately get it. Maybe they continue to get standards of care, or they get nothing for a while, and then eventually they receive the treatment. And so you look at that data where they're not receiving treatment and see if, and compare that to the people who do get it, like right away. And that to me is just more functionally useful than doing a placebo that is functionally useless in these trials. So we just need to kind of convince some of these regulators that it's not worth doing. That's what they know, but we've got to update our way of thinking about it.
Right. Well, I couldn't agree more. And we've talked about this before. I'm doing a lot of thinking, and I think this study is really helping inform a lot of this thinking too, in terms of what information really matters for the audiences that we need to convince to help us get to the next step, right? And I think one of those audiences, from my perspective, is the Oregon legislature, right? Especially when it comes to OHP, which is the Oregon Health Plan, for those who don't know, which is, the Medicaid folks here in Oregon. And, in my mind, and from my experience working with electeds, right? I mean, they like things simplified, for better or for worse sometimes. But I think the questions that feel worthy of trying to answer are, how does psilocybin therapy stand up next to what we're currently investing in the state from a behavioral health perspective? What's the efficacy? Is it just as good or better or worse than? I'm willing to bet it's better than. And what's the cost compared to current spend? And so You've obviously been thinking about this a decent amount. What is the biggest comparison that you would want to do a side by side with in terms of like what, like let's talk about depression, right? So is it talk therapy that the state is paying for? Is it antidepressants? Like, is it a combination of those things? Like if you were to set up a Medicaid side by side kind of study, psilocybin therapy versus what do you put in the current behavioral health bucket that we're already doing?
Yeah. So in the case of, well, this is generally true of both depression, anxiety, and PTSD, that the standard first line treatment is either psychotherapy alone, pharmacotherapy alone, antidepressants, things like that,
Right.
or the combination of the two. And so, the pharmacotherapy, when you're talking about off-patent drugs, and a lot of them are off-patent at this point, it's not terribly expensive, right? It's an initial medical consultation, a prescription, and some follow-up consultations down the road. Psychotherapy is a little bit more expensive because it's a clinician's time and it takes a certain frequency to get much benefit from it,
Right.
and that can sometimes be a long time. And these medications can go on for a really, really long time. So
Right.
an important dimension in all of this is that time duration of treatment, right? And so the question becomes, because psychedelic therapies are more expensive up front,
Sure.
right? Because you're having that, maybe a medical screener and a facilitator or therapist doing all the preparation visits, which, is only a handful of visits. But then you have, 1 to 3 psychedelic sessions maybe, that are basically full day experiences, and then a couple follow-up visits. So that ends up being several $1,000s, anywhere from $2,000 to $4,000 or so for an initial course of treatment. But it would probably take a couple years to reach that amount of spend for the current first line treatments of psychotherapy or pharmacotherapy, right? So the question becomes, where's the cutoff? If psychedelic therapies are more expensive up front, but they save money in the long run because people aren't on drugs forever, they're not in psychotherapy forever, being paid for by that health payer, what is the point at which money is saved?
Right.
Right. So, if someone gets a lot of benefit and they're on an antidepressant for a couple of years and then they come off of it, because things just get better, it works, life changes, whatever, then that's the cheaper route to go. And that's
Right.
usually why payers have this whole tiered, first line, second line. We don't pay for the more expensive stuff until the cheaper stuff has failed to
Right.
have a curative effect. Right. But if psychedelic therapies can be cheaper in the long run, and we can identify what are the cases in which it's cheaper in the long run to pay for the more expensive intervention up front, then that becomes the reasonable thing to do. So to answer your question, how I design a study is it needs to be multiple years long. So it has to be kind of a long-term follow-up. And that can, just include someone, one group of people gets the standard of care, and another group gets a psychedelic therapy at a similar time point. Maybe that's a new diagnosis or whatnot. And then we see what's that total health spend over time for that person. And do the people who go through psychedelic therapy stop needing as much healthcare or mental health care support overall?
Right.
In order for us to really say this is cost effective, we need to see data that would support a claim like that. Of course, that data does not exist right now,
Right.
but we ought to, I think, start designing studies that will collect that sort of data.
Could not agree more. And the more that I continue to think in terms of the shoes of legislators and what I want to hear, and doing some of my own, research on current spend, I've been thinking a lot about, I don't know how to define this. I'm sure there's a official definition for this type of population, and maybe you can help me find that word. But, there's an 80-20 principle that comes in here in terms of and I'm just pulling this out thin air, but if I had to guess, like 20% of maybe the most chronic patients, or maybe chronic's not the right word, or treatment resistant, depression or something, make up for 80% of the costs. Do you, if we were like, let's pretend we're putting on our study design hats right now, would you pick a population that's earlier on in their potential road and just in depression as that is defined? Or would you want to look towards people that are further down that seem to just continue to cycle through the program and are not getting better? Like, is there a demographic that, you would prefer for whatever reasons for this type of study?
Yeah, that's a good question, and I think from the healthcare payer perspective, as I alluded earlier, if like someone takes some antidepressants and they get better, then that's always going to be the cheaper thing to do, and so that's partly where we get this term treatment-resistant depression from.
Right,
is really not so much that that's a different type of depression. I mean, maybe it is in terms of underlying reasons why some people don't respond to these treatments, but it's more of a almost like created by insurance payers. Like, who does the cheap treatment not work for? And if it doesn't work for them, then we'll pay for these more expensive things like transmagnetic cranial stimulation or ECT, electroconvulsive therapies, and these other things that are more intense, but also a lot more expensive.
Right.
And so it would make sense to kind of maybe start there, but it's also, so I'm a naturopathic doctor, right? And one of our core principles is prevention, and so I find it somewhat problematic that we're always thinking only from this payer perspective of doing the
downstream instead of upstream.
Right.
Yeah.
There's some logic to let's start with the people who are worst off, that the treatments don't work for. But then there's also this prevention perspective. Like, if we offered somebody something that we know works, even if it's more expensive, could we prevent them from becoming, this more chronic sufferer? And someone that is going to generate a lot of expense, for the state. Because once you've, spent a lot of money trying to treat someone, even if it's the cheap method, and waiting till it fails, you've already spent a bunch of money on them at that point. So why not just start with something that, maybe theoretically has a higher rate of return in terms of its therapeutic outcomes. But, I say that, and I have to be put my scientist hat on here and say it with the caveat is that, the data we have on psychedelics is still a relatively small data set, and so some of these things need to be removed. And so we're talking in potential here, but we need a lot more data to support some of these claims and be honest about the outcomes. Right.
All right. So I have one more study design question, and then I want to get into the actual meat and potatoes of the study itself. So one of the things that I think you've said publicly is that participants came in nervous about the group format and ended up actually describing it as something that was more than just a cost savings part of the design, right? I think we in the space talk a lot about what are all the different levers we can pull to bring down the cost for the client, right? And group sessions is maybe one of the biggest ones right now. So tell me about that. That's really interesting. There's a financial lever there, but there's something else there too. I mean, talk to us a little bit about what happened in these rooms in these group type of settings for these folks.
Yeah, there's multiple components to that. One is, as you said, just purely the cost effectiveness angle on it, that when you do it in a group, the ratio of labor spent on the professionals running a thing is more effective. It's like the way we did this study was groups of 6, and we had to follow Oregon's rules around facilitator ratios, which are honestly still kind of debatable. Are those ratios appropriate? Could they be a little bit bigger? A little bit? Should they be smaller? Whatever. But what we had was groups of 6 with 2 facilitators, and that worked really well. So, and I'll show you a slide a little bit later on the numbers, is if we had done everybody in this trial one-on-one instead of in groups, what would we have spent versus what we actually spent because we did them in groups. So, I mean, the math is pretty easy to do in that regard. It's cheaper to do group work, cheaper for the participants, cheaper for everybody involved, right? So that is an easy case to make. But what's a little bit a tougher sell and is more of a cultural thing. We live in a very individualistic society, and people, we all to some degree, I think, struggle with being vulnerable. And so when someone has, a mental illness condition, they're feeling depressed, they're feeling anxious, or their trauma is really unique to them, we tend to, or we can frequently isolate ourselves and think that our experience is really unique and no one understands me, and other people might be jerks, they might judge me, and so it just feels safer to be in this one-on-one therapeutic relationship. And I'm not trying to make the case that group work is appropriate for everybody, and there are people actually that I screened out of this study not because they wouldn't be good candidates for psychedelic therapy, they just didn't feel like a good fit for the group.
Right.
Maybe they were more, their trauma wasn't at a state where it was conducive to be in a group, because in some cases, if there's a lot of trauma and reactivity from that trauma, they just need a lot more attention.
Right.
And when you're in a group, that's like one facilitator on one person, giving them a lot of attention. It reduces the availability to support the whole group, right? So that might be one scenario. Or someone who's like really, really talkative and wants to talk all the time, or whatever. There's just people who just aren't a good fit.
A lot of dynamics in the group setting, for sure.
Yeah, but for most people, there's just a general reluctance to it. And because this study was funded and participants got to do it for free. In fact, we paid them a small incentive. They got $200 for completing it. But for a lot of them, it was their only way in. It's like it was like this study, or did they just don't do psychedelic therapy? And I hope that doesn't sound manipulative in any way. It's just that that's the design we had, and so that was enough to sort of nudge them in, toward doing it, of their own free will, of course.
Yeah.
And what they found though was, as I described it, I talked about, how we facilitate and we make group agreements, and everybody gets to meet everybody and share a little bit before we get into the psychedelic experience, and that, if stuff comes up, we can process it together, and yada, yada, yada. There's all this, support being offered. People like calmed down a little bit. They were a little bit nervous the first time they met, but then they got to know each other, and it opened up. And what we found is several relationships were formed, like friendships, with other participants. And a lot of people reported being really thankful for the group format, because when you're in a group, you're witnessing other people doing their work too, and you learn that maybe our stories are different, but the themes of our struggles and the things we overcome have these similarities, and I don't feel so alone anymore in the way that I suffer, and that can be really powerful. You can be inspired by other people, and so it's just, this is beautiful things can happen, and they can be challenging. There's the person who shows up late, or maybe talks a little bit too long.
Sure.
And so there's little annoyances that always happen with group. As an organizer of groups, it's challenging to get people to find the right schedule and deal with all these things. So groups are not easy, but they can be really powerful and really, really effective. And it's really true that the whole is greater than the sum of its parts often in doing group therapies. And I didn't include it on my slides that I'm going to show you here in a minute, but one of the results that I was most impressed by was the ability to function in social settings. I can't remember the full jargony word for it, but it's one of the dimensions of the Promise 29 scale, which It's 29 questions. It asks, a few questions each of depression, anxiety, pain, cognitive function, sleep, et cetera, et cetera. But one of them is ability to function socially. And, it went from like a fairly dysfunctional average rating among participants to way better. It's one of the strongest effects in the whole study.
Wow.
So you could say that, maybe that just correlates with depression generally, and maybe that's true. My little study doesn't have strong enough, numbers to prove that. But
Sure.
Nonetheless, it was one of the stronger results in what we found. And, maybe some part of that was just doing this therapy in a group format. So I'm a big advocate for group work, not only because it's cost effective, but also it's therapeutically effective for a lot of people.
Yeah, absolutely. I mean, just being able to open up a little bit prior to any session within a group and get to know people and to see that, like you said, other people are struggling too. And that maybe makes me a little bit more okay being public about struggling myself, right? There's a lot of, as someone who has been through a lot of talk therapy and who has also participated in men's groups, that was incredible work. That's work that I've taken into my own psilocybin journeys, within the Oregon program. And so, yeah, it definitely paves a path for folks who are willing to walk down it in a way that individual sessions don't. Individual sessions can offer other things too, for sure. They have their own benefits. But I recently did a group experience within the Oregon program and walked away definitely feeling a profound appreciation for the group setting in ways that I did not think I would. I mean, I'll give you like my partner runs a travel business and she takes groups like around the world to Japan and Mexico. And I've always kind of been like, I'm not really a meet people I've never met before and group traveler. And I don't know, like maybe I actually will be someday. And my perspective started to change a little bit actually after a group psilocybin experience. Yeah, so, amazing. Yeah. Let's jump to the study. You want to pull up some slides to do that, or how do you want to get into it?
Right. So obviously I've said a fair amount about it already, but I'll just show you a few slides here. Caveat here for the scientists, this was a feasibility study. So the primary outcome is just, was this intervention feasible in terms of, safety, or not efficacy, but safety, retention, that sort of thing. So we were able to recruit fairly easily. We only had one person drop out. So we enrolled 20 people, and only one person didn't finish. So high retention rate. And we also asked about satisfaction, and on a 5-point scale, the average was 4.8. So we had a couple vomiters, two, I think, some nausea and kind of the expected side effects you get from these things, but no severe adverse events. So really, all across the board, all the feasibility outcomes were positive.
Right. And what was the dose? Those are the different doses per individual? Were they all on the same dose?
We gave them a range.
Okay.
And part of that is, unlike an FDA study, I was, not prescribing or administering the medicine, right? So we're in the Oregon model, facilitators aren't even allowed to touch the mushrooms, right? So we didn't feel like it was appropriate to tell them exact dose they could use. So we gave them a range, though, just so we didn't violate the facilitator ratio rules and whatnot. So everyone did between 18 and 35 milligrams, except for a few people who are on SSRIs. We allowed them to go up to 50, which is the maximum allowable because of the blunting effects. But everyone did B positive strain psilocybin cubensis mushrooms in a tea. And then the other thing to say is we did 2 online preparation sessions, and then they had 2 psilocybin sessions about a week apart. And those were followed up with online integration sessions that we did all together. So everything was together except for the initial screening visit. That was the only individual visit. And these are the results here you're seeing on the screen is the Hamilton Depression Rating Scale, which just gives you, a score. People rate their depression on these, to give it a metric. where the average was already the very severe depression on average for the group. And you see the red line is the mean or the average across all participants, and the blue lines are each individual's scores. So really, really strong results there. And, we had a few people kind of had a sort of relapse of depression afterwards by the follow-up period, which was 3 months after they finished. And, we also did qualitative interviews with them at that follow-up visit. And those people whose depression went back up, like one of them had a breakup, another had a death in the family with like a whole estate fight with her family that was really ugly. And, it's just like life was happening, for these people. And it was really, it was understandable. But even they reported that they really benefited from the participating in the trial. Nonetheless, they learned something about themselves. They picked up some tools that were helpful for them. So really positive finding here. And then I mentioned, the Promise 29 was the other set of questions we have. And surprisingly, all of those were statistically significant on a t-test, what's called a t-test. A range of effect sizes, which means some of them were kind of more modest, but all of them were at least modestly effective, and some very strongly so, ranging from improvements in anxiety, sleep disturbance, and fatigue, pain perception. That was one of the weaker ones because we weren't focusing on pain, but we had a few people with chronic pain, and they felt that improved for them.
That's something that Adi Ray and I talked about a couple of weeks ago. Actually, I had asked her what was, one of the most interesting things that she didn't expect that they're kind of seeing in some of their research. And that's, because she's done a lot of work in cannabis and chronic pain, and the fact that that seems to continue to show up like across multiples of these studies. It feels like it's important to, even if you're not looking at pain or other conditions, to ask a couple of questions just to, see what things are showing up as, before, during, and afterwards.
Yeah, exactly. You never know unless you ask.
Right.
So this was the slide I had mentioned earlier around costs, and some of these numbers are a little bit like we had to decide what to pay a facilitator, and so a lot of Oregon facilitators are not licensed healthcare professionals, and so they might charge slightly less than this. This is the kind of the lower end for what a psychotherapist might be paid on an hourly rate. But nonetheless, that's the number we based it off of. And you can see with 2 psilocybin sessions plus integrations and preparation for a cohort of 6 people, the total cost was $11,500. And if you had done the same amount of treatment one-on-one, that would have cost nearly $27,000.
Wow!
So less than half the cost by doing it in a group. So that's a pretty big difference.
Hey folks, I just want to take a quick break to tell you about one of my favorite psychedelic resources for people considering psychedelic therapy, Althea. We all know someone who is suffering and might genuinely benefit from psilocybin therapy, but the truth is they have no idea where to start. I've personally lost count of how many texts and phone calls I get from friends and family asking this very question. That gap between knowing that this care exists and actually getting to it is one of the biggest barriers for individuals looking at state-based psychedelic programs right now. Althea is built to close that gap. They're a guide for people trying to figure out how to access legal psychedelic care, helping you understand what's right for you, and connecting you with vetted licensed providers and state-regulated programs in Oregon and Colorado. The hardest part of psychedelic care isn't deciding that you're interested. It's figuring out what's right for you, and more importantly, who to trust. If that's where you are or where someone you love is, Althea is a great place to start. You can head over to their website, withalthea.com, and we've also included a link to their site in the show notes. Okay, back to Matt. Yeah, I mean, it does really make a compelling case for, again, both on the financial and the potential efficacy within that type of setting as well. It's really interesting. Would you add if the state asked your opinion, like, we're thinking about, doing a Medicaid pilot for psilocybin therapy, like, would you recommend group setting? And obviously there's a lot of parameters that, like, let's just say you get to dictate what the parameters are if you had full control over those. Would you recommend a group setting for depression clientele on OHP?
Yeah, I mean, that's a great question that I'm sure there would be a lot of debate over.
No doubt, no doubt. Well, I hope someday in the future, very soon, we're going to have that fruitful discussion. Hopefully, it doesn't turn into a debate. But
yeah. I mean, I think I felt really confident in doing this as in a group format, but in a sufficiently large study, you're going to inevitably end up with some people who maybe don't belong in a group.
Sure.
And
we're talking like 200, 300 people, like you're bound to they're not all going to be perfect groups, right?
Right. And that's a very real world concern, right?
Right.
And so you don't want to, if you're going to consider this a real world sort of study, like that's just going to happen. One person's going to get into an intervention group, and it's going to have a negative impact on other people in their group. Right. So that's going to, skew the data, but in a way that's very real world.
Sure.
So that's something to be careful of, and also including, facilitators who are well equipped and trained to do group work, which is not exactly the same as doing one-on-one. There's additional skill sets needed there.
Yeah.
But yeah, I think I would advocate for it. I think it makes an even stronger case to the state, but there also needs to be an allowance for one-on-one sessions, and how to make that determination is tricky, right? Because if you just ask the patients, 90% of people are going to say they want one-on-one, and that's obviously more expensive to the payer in the end. So it should be almost like, maybe, I don't know, that you prioritize group work and you have criteria at the screening physician or professional screener person to determine this person would be a better fit for individual.
Well, like an off-ramp to an individual session. Yeah. Okay.
Yeah. That's a good question though. Like, what should we advocate for? Not sure. I would probably lean toward doing group work, but that would need to be. It
needs to be done right in order to be done at all, right? Like as right as can be, right? I mean, there's no perfection in terms of the group work. That's really what I'm hearing loud and clear.
Yeah.
Does 6 people feel like a sweet spot? Is it a misnomer to even try and define the number of people, or
it's only a sweet spot because of the rules in Oregon.
Okay.
So they have these ratios that are based on dose ranges. So if anyone up to 35 milligrams of psilocybin analyte, it's a 1-to-4 ratio. So you could have, I guess if you've made that your max for the intervention, 35 milligrams, you could have 2 facilitators doing up to 8 people. And then it just depends on, having the right service center or facility that can do a group of 8, because that requires a fair amount of space to do it that way. So that, we did it 1-to-6, partly because of the service center we used. 6 was sort of the max in their biggest room.
Sure. There's always physical space constraints.
Right. So, but I'd also say it depends on the group. I consulted when I was designing this study with Christopher Stauffer, who has done. I'm sure you've heard of him.
Shout out, Chris. I'll put this episode in his inbox.
He's done some group work studies. Some of the few. And it's like, hey, what's your feedback? How do you determine ratios? Like, what's your guidance? And he was incredibly helpful in having that discussion with him. And what he pointed out was a couple things. One is, depends on what you're working with. Trauma, a lower ratio is more advisable, because people just tend to
Triggers
have,
abound.
yeah, you need more support generally than someone who's just depressed, right?
Right.
So you can have a potentially bigger group in a depression group, or not necessarily bigger or smaller group, but the ratio of support is important
Right.
there. And then, also from substance to substance, he pointed out, because he's done both MDMA studies as well as psilocybin. MDMA is a much more social
Sure.
drug.
Yeah.
It makes people like want to talk and share and open up and connect. Psilocybin is not to say that people can't connect; they can be
A little more
activated, but
inward. A little
it's
more
more of
inward.
an inward experience, right?
Yeah.
And sometimes what they're talking about is complete nonsense in the moment,
Right.
right? So it's not conducive to a lot of group sharing during the experience itself, and so which is also to say, in terms of ratio, that you could theoretically have an MDMA group where there's agreements around interaction, but you want to be careful around that. And then with psilocybin, comparatively, could be a larger group in the sense that if the agreement is you're kind of inward and quiet unless you really need some support or something. Yeah, so all of these things really make a big difference on who you're working with and what those ratios ought to be.
Yeah, totally. All right, walk me through some of these limitations and next steps to the extent we haven't already hit on them.
Limitations, as I said, this is a really small study. It's feasibility, so there's no control, and we followed state rules here, and so there's a lot of working around those rules. And I was I did it as a licensed facilitator, but I also did the screening visits I did as a naturopathic doctor, because under that scope of practice, I can make a diagnosis and recommend continuation or discontinuation of a pharmaceutical or something that people were on. So those sort of limitations were had to be explained thoroughly and were a little complex and whatnot. But we got through it. There's no control. As I also said, it was a small sample size, and it was a biased sample toward people who were pro psychedelic. And I remember you asked this actually, and I didn't respond to it earlier. Just about the group, it wasn't super diverse. We had I want to say like 2 or 3 like non-binary folks and or queer folks, but it was mostly straight white folks was kind of the biggest demographic there, and I mean part of that is maybe who we were recruiting from or what our population we were already connected with. Certainly wasn't intentional, and we tried to create as a diverse population as we could. But it was also facilitated by 2 straight white people, and so that is part of I think the challenge in not necessarily the challenge, but something that I envision for a better version of this study is to have at least offer affinity groups with facilitators who fit different demographics. A BIPOC group, maybe a Spanish-speaking group, a group for queer folks, or some combination of those. And of course, they can have the default groups that are open to anybody, but have those affinity groups for those who feel more comfortable in those sort of settings. Of course, it takes a large enough study with enough funding to have the capacity to have these specialized groups, and then recruiting from these minorities to get them all in the same place in a group setting all at once at the right time is really challenging. But it can be done. It just has to be, planned carefully. And I think that's something I would endeavor to do with a bigger, better version of this study in the future.
Right.
And, I would also love to recruit from a more generalizable source. So rather than just saying, hey, everybody, psychedelic study, come and get it. Going out to community mental health clinics where people are showing up, just like, hey, I need treatment, I'm depressed, and say, and have them, refer appropriate people to the study, and who may or may not know or be familiar with or have feelings one way or the other about a psychedelic therapy, and that is who can really give us a more honest assessment of expectations and potentially be good controls for giving us more realistic data.
What is the current referral pipeline from behavioral mental health clinics to psilocybin therapy look like right now? Does it for you? And I guess maybe that's a question for you in your practice. I don't know if you can speak on the whole industry, but are folks referring into the program? How does that happen?
Yeah, a little bit. Well, and when I say community mental health, usually I'm referring to more like county or city funded clinics,
like CCOs, basically.
That are
community care organizations for those who don't know.
More conventional services, and you really don't have, to my knowledge, anyone doing anything, recommending any psychedelics in those environments. But in the more the wider sort of sense of community and clinics and clinicians working in mental health spaces. It's a mix. There's quite a there's a fair amount of awareness out there, and we do get referrals from. I get that in my clinic where people are showing up for ketamine services, ketamine therapy, and it's just like, how'd you find me? And it's like, oh, my therapist just told me to Google ketamine assisted therapy, and you came up.
And there's Matt Hicks. The SEO's working at least.
And the same for psilocybin too. There are mental health professionals who don't necessarily do the psychedelic work who are starting to refer to psychedelic therapies. So that's happening for sure. And and it could be improved as well. And part of that is just having more data and more public awareness and needing to see some good results too, which we're well on our way.
Yeah.
To wrap up the clinic or the results here is just to say that working with a low income population with depression in a group format was demonstrated to be safe, well tolerated, and acceptable. So, and then the clinical indicators that we saw, while not definitive because it's a small group with no control, I did show signs of benefit, and we ought to do more research like this, in my humble opinion.
So what does more look like? What does more get into, more of the efficacy side? What does that design look like based on what you've learned from the first one? And most importantly, what does it cost? What is it going to cost to get it done?
Yeah. Well, I mean, the cost just depends on how big we want to go with it, right? It's like if we wanted to do it with, send 500 people through it, then that's going to cost a few $1 million. But if those would give us stronger, more definitive statistics. Usually you don't jump from a tiny study like mine to something that big. There's usually something more moderate in between. But in terms of the study that I would like to see next, it's very similar to what I did, but I would do what's called a step wedge. So some people would be randomized into going straight into the treatment. A very similar protocol to what I described here, and some people would be in the waitlist control, so they might go 3 or 4 months without receiving treatment, and they just sort of continue doing whatever that is, whether it's receiving treatment or no treatment. And we're continuing to ask the same questionnaires of them and seeing, do they improve while they're waiting? Most likely, you would expect they won't. But then at the end, after their waiting period, they get to go through the treatment. And so you compare treatment to those who didn't receive treatment initially. And that's a decent way to compare outcomes there. And so, doing it with a group of at least 50, this was 20 people and 19 finished. At least 50 would be a worthwhile study, and that's probably going to cost at least $250,000, probably a bit more if you want to do it well designed. But I would also advocate really for going a bit bigger than that to 100 or 200 participants, and there you're looking probably ballpark of $1 million or so to get that done. but again, a lot of factors dependent on there, and how it's done and what time might get donated, or how many participants and how many treatments.
Right. Well, that was going to be one of my kind of wrap up questions here, is in terms of time. What was the timeline, like start to finish, for this? And I'm like, including whatever time it took you to raise the funds to do this one, or like, start to finish, how long was this project?
Yeah, so I was doing it through the National University of Natural Medicine, which
Right.
is a small institution, but there's some disadvantages in being with a small institution. But one of the benefits is that you can move things along pretty quickly. Like our IRB, our Institutional Review Board,
Right.
can review something much quicker than like an OHSU does.
Sure.
And so I was fairly efficient with it. So from the time I started writing up the protocol and the IRB submission to the time that I collected the last data point, which was the last follow-up interview, that was probably, I don't know, I want to say like maybe 14, 15 months.
Okay.
So a little over a year. And of course, I'm not counting publication, which
Sure.
is,
Sure. Yeah.
can take
yeah,
much longer
yeah.
sometimes, but
Right.
just from conceptualization to getting it written. Now, a bigger study is going to take longer than that. Just,
Sure.
There's more money involved. There's usually more oversight. There's more approval processes and more clinicians to get involved and have meetings and get trained to make sure we're using the same protocols and all of that. So it gets a little bit more complicated. And, you might do multiple iterations, right? So this was,
Sure.
we did 4 cohorts. I don't know if I mentioned that. There are 4 cohorts of this group, but just one facilitation team, which was
Right.
me and my wife, Olivia Hicks.
Right. Shout out
But
Olivia.
Yeah, multiple teams, doing multiple things. There's a lot of scheduling. So my point is, it could take a bit longer.
Sure. Yeah. So if, and this is where we get to dream big here a little bit, do some manifestation. 250 people, and we're ballparking numbers here, like 1.5 million, 2 years. Those ballpark estimates feel close. I'm leading you to the parameters of what we should start messing around with for a legislative ask here, if you can't tell.
Sure. 2 years, I would say, to like 2 years maybe
Right.
to get
Okay.
kind of halfway through the actual intervention. But
Okay.
as I mentioned, there's a need for that follow-up period.
Right.
And so that's where these things, that's why you see a lot of publications for the same study come out, because
Sure.
they'll publish a protocol, and then they'll publish when the last participant finishes the intervention, and then a few
Got
years
it.
later they publish another one that's follow-up data. And that follow-up data in this case is really important, especially when you're talking about cost effectiveness, for all the reasons I yapped about earlier.
Right. We're talking about the
Like, look at
longevity
longer
of the
term.
effectiveness, right?
Yeah. And this one, what I would propose is this like wait list group. So you have people just sitting around doing nothing for months, and then getting an intervention, and then a follow-up period. So
Right.
it takes a long time to do good research like this. So
Yeah.
probably this project wouldn't really be done from concept to total completion for like maybe 5 years.
Sure.
know?
Yeah. Makes
Or
sense.
so, depends how it's designed, but
Right. Yeah, totally.
ballpark parameters there.
Yeah. So are you working on the next design now? Are you looking for funding now? Are you ready? Like if someone's listening to this podcast and is interested in learning more about how they can, cut you a check, are you ready to have those conversations?
Well, that's a great question, Sam. Thank you. Great. Yeah. So I do have a couple different versions
Sure.
that I have already submitted to grants, and or I should say more like they're ready to be submitted.
Gotcha.
But it's for NIH grants. It's always a shot in the
yeah.
dark.
For sure.
And so
Yeah.
I don't know that anything I've submitted so far will happen. But yeah, I have a couple different iterations, and I change them and alter them all the time to come up with a better version of it. Or
Sure.
sometimes different funders have different priorities, and they want to see something slightly different, and it can be adjusted in that way. So yeah, I have a good starting point, and it's not done, and it's
Sure.
at a point where it's malleable depending
Yeah.
on the interests of a funder, potentially. So yeah, and I'm also working on another small literature review now on psilocybin cubensis, the mushroom itself. And my hope is from that to also submit, some grant funding to do more research into the mushrooms. We still know
Right.
surprisingly little, and there hasn't been a ton of actual psilocybin mushroom research.
Right.
And anyway, I could go on a whole tirade about how people even publishing these papers that literally even have the mushroom name in the title, and they're not about the mushroom.
Yeah, sure.
So anyway, I'm trying to remedy that as well, and
Right.
hopefully do some research here in Oregon on mushrooms. We've got mycologists here in the state, and
Yes, we do.
a lot of clinicians with a lot of experience that could run those sort of trials. So that's another sort of gap in the science that needs to be filled as well.
Yeah, right on. Well, two final questions. Where should people go to learn more about your study, your work in general?
Yeah, so I'm also the founder and president of Synaptic Institute, which is primarily a clinic, but we also have some educational programs, including those for folks trying to learn to provide ketamine-assisted psychotherapy on there. And we have an emphasis on research, so the clinic also supported this research project in addition to the National University of Natural Medicine. And so I have all my research on a page there, and you can go to synaptic.institute/research.
We'll put it in the show
you'll
notes too. Don't worry.
So there'll be, that's a tricky one to spell. I'll grant that. But I have all my publications, people can download and read there, and as well as a full slide presentation for the study.
Incredible. Any final thoughts for our folks before we wrap up here?
Yeah, keep trying. With all of these things, we've got this, whole thing, this executive order from the White House that seems like indicators, but not really concrete things. And it just, it's a positive sign, but a need for really ongoing advocacy. And, I would also just say too that, these things are slow, and even here in Oregon, I hear a lot of people. I'm also on the board, the advisory board, the Oregon Psilocybin Advisory Board.
Yes, you got a big shout out in the listening session earlier today, by the way.
Oh, did I?
Yeah. Maybe that's a reason to listen to it. You can fast forward through it. There's a lot of dead time in it, but you got some good shout outs from Heidi Venture for your good work on the board. So I'll echo that.
That's sweet. Thank you.
Yeah.
So, the point I was trying to make is just like it takes a lot of advocacy, and right now what we're seeing is a decline really in participation. When during the development period, there were a lot of voices and opinions, and it's really died down to the point that people who do show up, their voices carry further. So I won't go into the details here, but I hear sometimes these complaints and people still referencing that like OPS doesn't listen. They haven't listened for 3 years. And it's like, well, there were a lot of voices 3 years ago. There's not as many now. And, and also democracy is slow. This is a very democratic process, and, you're not going to win every battle, and people have different opinions, and that's the way it goes. But if you're persistent, if you're organized, you really understand the issues, the system really can and frequently does work, but you have to keep showing up. And so that would be my word of encouragement for folks.
I mean, you basically just made the case as to why I call this podcast Ground Game. I mean, the whole thing is the ground game. It's the people that show up. It's the people that know that complaining alone doesn't do anything, especially when you need credibility with decision makers. But when you do show up repeatedly and you're organized and you understand the people and the process, and you remain curious as opposed to reactive, it can go a long ways, right? I mean, this, maybe pie in the sky idea that I have that we can get a couple $1 million from the Oregon legislature next year to test out and continue to make the points that you've been making with some of your initial studies. A lot of people call that crazy. I'm not interested in doing anything, taking, small 2-pointers anymore. It's time for some half court shots. There's only so much time that we have to take those, I feel like, at this point, so we're gonna give it a go. And I think it's thanks to folks like you doing this type of work that's really building that foundation and the layers on top of it. And we just got to keep building.
Yeah, and I appreciate that, Sam. Thank you, and thank you for all the work you do. You've been an incredible advocate for this, and a very grounded and consistent voice in all of it, and haven't given in to the temptations of hype or reactivity as far as I've seen. So I appreciate you as a source of reliable information and grounded perspective. So thank you.
No, thanks, Matt. I appreciate that. Yeah, it took a village to get here. It's going to take us a village to go where we're going. So all in it together. Well, thanks again, Matt. Really appreciate the time. Again, check out the show notes if you want to learn more about Matt's work. You want to support Matt's work. It'll all be there. And Matt, really appreciate the time. I'll be in touch with you offline too about some more stuff on studies. And let's get Matt's studies funded, folks. This is how we're going to continue to make psilocybin therapy more affordable for folks who stand to benefit, but otherwise are just not going to have access anytime soon, if ever. That challenge is our opportunity, and I hope you join us in seizing it. Thanks, Matt. Talk to you soon.
Thanks for having me.